And in very classic fashion, I said the wrong name right before you left, to case of Maria. Not atypical of me to use wrong names. I apologize. We're looking at the case of Susan, but we're going to go over it anyway. So just sort of a way to fill in some little extra time that we had there before lunch. It's hard to time each segment so it ends in sort of a reasonable place with the breaks, but we're trying to. So. Okay, so let's go back to Susan. So this was the last slide of my last presentation. So we can see the neighbor coming in and checking on her. So let's see what happened to her, the next sort of stage of treatment that happened with Susan. So with Susan, after her neighbor found her, sorry, she came back, she had hallucinations. Sorry, let me just go back myself. So after she had an initial session, one crisis session, she was taken home, couldn't sleep, had hallucinations, and a lot of hypervigilance, clearly. Okay, her primary care physician prescribed by phone lorazepam, 2 milligrams, 3 times a day for grief. Susan screamed less, but appeared more disoriented. She would not get out of her husband's clothes, shower, or move out of the bedroom. She would not eat and barely drank liquids. She lost the ability to read or maintain focus for longer than a few minutes and began drinking to dull the pain. The HMO authorized another crisis session with another provider where she had to recount the story again. In the next days, the police questioned her multiple times about the suicide. Susan was again taken to a crisis therapist to recount her story. Finally, she was taken to her PCP, who sent her to the emergency room where she was held down for IV lorazepam for her, quote, tremors. Susan was sent home. 3 weeks later, her neighbor found her disheveled and disoriented. So what we're going to do is look at some of the post-traumatic risk factors, and then we'll talk about the treatment of Susan after we start on treatment. So let's go back to this, what happened to her afterwards. And can anybody tell me what post-traumatic risk factors that they saw happen to Susan? Good. Get some good ideas out there. Good. Alcohol. So you guys are really getting part of it. So I see, well, so there's certainly with treatment, but we can't say it was appropriate treatment, right? Yeah, so no proper, doesn't look like a proper diagnostic assessment, what was going on, no social support, right? She was already disenfranchised from the community, and this sort of retelling and re-traumatization. So let's look at it. So some of the post-traumatic risk factors, as many of you got, was this re-traumatization. So the first re-traumatization was actually, remember when she was found, she was lying by her husband's body. So there she's already traumatized, and she has to be there lying next to the trauma itself, and was confined to the scene of the trauma. She couldn't escape for whatever reasons. And then she was re-traumatized by multiple therapists with sort of this critical incident debriefing approach, and by the police as well. She had this forced intervention with fluids, so this sort of medical trauma that's adding to further stress. And she had a loss of spouse, and her social support as well with the suicide like that. No resources seem to be given to her to help support her, and just the suicide itself would have a low cultural acceptance. inappropriate treatment. Like I said, there was treatment, but it was inappropriate. So her prior mental health conditions were not addressed, if she had any. The benzodiazepines were given over the phone for, quote, grief. So first of all, you don't give benzodiazepines for grief, certainly not at that high quantity. And then she's also abusing alcohol. So we have the alcohol abuse combined with benzos, and I'm sure you've learned that's not a good combo. No therapeutic alliance was established, and definitely no sort of paced therapy to her tolerance. So we'll come back to Susan again after we learn a little bit more about treatment and to see what else probably should have been added to it. Yes, benzos are also contraindicated for PTSD. That's right. In fact, there's worse outcome with PTSD. So we're going to look at the sort of the when to treat. So, you treat, some of this is, there's obviously going to be different points of view when I talk about this. I'm sure within, the VA, there's certain sorts of protocols that you have to follow. So some of this is how I approach it. Some of it is, really what I consider to be pretty good treatment that when you look in the literature. So, there's going to be some sort of give and take on when I talk about this. So in general, my opinion, and I think in the literature too, is that you really triage everybody, and the earlier intervention you can get with somebody with a trauma is this treatment pretty quickly, particularly if they're vulnerable individuals, and they may be vulnerable for various reasons that we've talked about before. So often people do not seek treatment immediately. They try to get over it. And part of the reason, at least that I run into a lot, is they really don't want to have to relive the trauma by coming in and talking about it. So they may wait a long time before they get into treatment. Patient treatment choice is very important. So the literature shows that if the patients are given their right to choose what way they want to go, it's going to be a better outcome. And by APA guidelines, the patient gets to choose the treatment, and most will choose therapy over medication. Some may seek only very short-term treatment, only either medication or therapy. So there's a substantial portion of PTSD, particularly longstanding PTSD, which is going to be treatment resistant, which then we think about that switch, combine, augment a sort of approach with different therapies and different medications, sort of how we learned about depression, this switching or augmenting approach. So the red flags that are going to indicate more likely to need medication. So this doesn't mean they're the only medications that are going to, cases that were more likely to need medication, but it certainly is a red flag for the clinician to see. So if there's suicidality, always we want to think about some medication as being helpful for suicidality, risky behavior, significant sleep disruption. So less than 4 hours per night for 3 nights is a marker used. Again, I often see sleep disruption. Even if they fall asleep pretty quickly, there's this early morning awakening in many, but again, there's always different presentations. Significant weight loss, and the standard is of 1 week, greater than 2% of body weight, or 5% at 1 month. So there may be, complete anorexia at the beginning of after a trauma, just inability to eat. If there are significant co-occurring disorders, and certainly if there's psychosis, we want to think about treating with a medication. And if there's severe functional impairment or distress, and in the case of Susan, there was certainly that functional impairment. So this is October 2017. It may not be the most recent, but I think it's probably not changed much since then. But we can see where the arrow that I've added here in this, let me get my little thing here, my annotation selection. So I've added this here, is that trauma-focused psychotherapy is the first-line treatment for PTSD. It is not medication, it is psychotherapy. So these are sort of the percentage people who receive trauma-focused psychotherapy who will no longer have PTSD, about 3 months of treatment, 53 out of 100, medication, 42 out of 100, and with no treatment, only 9 out of 100. So people, really clearly benefit from the psychotherapy. Here, they're talking about the VA is talking about trauma-focused psychotherapy with cognitive processing, prolonged exposure, or EMDR. That is not APA first guidelines, but we'll come to that, okay? So here's the APA's best practice guidelines from 2017. So a strong indication that it works, or is efficacious, is CBT, CPT, cognitive therapy, prolonged exposure therapy. And then with a little more conditional treatment, it's EMDR, narrative exposure, brief eclectic, and finally that there is insufficient data for relaxation or seeking safety. Oh. People are having trouble with sound. Oh dear. It looks like it's okay now. All right. So medications, and Dr. Papp had mentioned also that just because they're FDA approved does not mean they're not used. So he's going to go into medications in much more detail. But the two that are approved, FDA approved, are paroxetine and sertraline. But then also the APA guidelines says fluoxetine and venlafaxine. But that there's insufficient data for risperidone or topiramate. Again, this doesn't mean they're not used. So, all right. These APA guidelines didn't address, though, some of the subthreshold symptoms of PTSD and treating those. It didn't talk about dose timing, duration, and cost. Clearly, some of these therapies are going to be much more costly to implement than others. And these other sorts of markers that go along with PTSD, like the quality of life, the substances. They didn't talk about, I guess EMDR would be maybe an alternative treatment, but they didn't talk about any other particular complementary treatments, particularly somatic sort of treatments that are coming into vogue now. And they didn't talk about other medications to target specific symptoms. Which we all along we've been saying, PTSD, that's particularly important, is to be treating specific symptoms for PTSD. So unlike depression, there is no large clinical trial that's been done for PTSD. I'm going to present to you again, just presented to us. No, this came from clinical updates, fairly recent. The second author of this is Murray Stein, who is at the VA. I'm not at UCSD, UCSD. But it gives sort of a treatment algorithm for PTSD. Again, this is not strictly controlled. It was done by a meta-analysis rather than a clinical trial. So for the first line, the newly diagnosed patient, you're going to give them the choice between psychotherapy or an SSRI or SRI based on what they want and what's available. So under certain conditions, there may not be psychotherapy available, but it is really the first line treatment is to treat with trauma-focused psychotherapy. But sort of the second arm of this is to treat with an SRI, so a selective serotonin reuptake inhibitor or serotonin norepinephrine reuptake inhibitor. And then you're going to get this sort of branch here where you've got these common comorbidities. So even if they've chosen the trauma-focused psychotherapy, you still can treat the specific symptoms that happen within it. So if there's psychosis, you can add an antipsychotic, substance use, borderline, prominent sleep disturbances. You're going to go ahead and treat those, even if the primary focus is with psychotherapy. And then with psychotherapy, we kind of look at this branch here. So if there may be a robust response to the PTSD symptoms, or it can be a poor response. So you can, at this point, if there's a poor response, which is psychotherapy after 8 or more sessions, then you can switch to another type of therapy, or you can switch to something like an SRI. from the medication arm here. If there's a robust response, you're going to go ahead and continue. As we learned with antidepressants, you can continue the treatment for 6 months to a year after the response. But if there's a partial response, then you can switch to another SRI, or you can augment, just as you would treat with something if it's more of a depressive sort of symptom, but you can try a second SRI. Robust response, you're going to do the same thing. Poor response, there's some augmentation with the second generation antipsychotic. And of course, anywhere in here, you could add the psychotherapy back in to this medication branch. So I'm going to kind of now pick it apart just a little bit. So I think you can see more quickly, more easily what's happening here, that this patient preference, let's get my thing back there, this patient, I'm trying to do the select tool here and it won't let me. Well, sorry, just a second. Nope, won't let me select anything. Okay.
Just click on the slide.
So you can see my pointer. So again, this patient preference. Okay, so the patient preference of the medication arm here is treating with the SRI, where you treat with trauma-focused psychotherapy. Again, these common comorbidities, you're going to treat with medication, these two different arms of medication or psychotherapy. And finally here, following along as we did before, this medication arm versus psychotherapy arm. Antipsychotic drugs are almost always used to augment an SRI and PTSD rather than, so we've got here an antipsychotic medication, and up in this arm here too, we have a possible antipsychotic used for the psychosis, but it's rarely used, as monotherapy. Prazosin typically augments an SRI, but it can be used as a monotherapy to treat specific symptoms. So you may, this psychotherapy arm, you may have to delay some of the psychotherapy if there's psychotic response until the psychosis has diminished. So are there any questions about this general, again, this is just a model that was recently presented as in a clinical update. Are there any questions about it? Okay. So let's look at this just very briefly. This double randomized trial of prolonged exposure versus sertraline for treatment of PTSD. And really, there was no difference between the two treatment arms and between the sertraline and the prolonged exposure. However, there was improvement depending on if the patient got to choose what type of treatment they got. So this idea of patient choosing their own treatment is very important. So when it says a trial, a second SRI, is that an adjunct? Not just increasing dose or whatever approach. Yeah, so if it says a second trial, it would be a different medication. So otherwise it would have said, let's go back to that. So you're asking your trial of a second SRI. So remember that you usually switch to a different class. So if the SRI was not affected in that case, you might go to an SNRI, for example. Or vice versa. Otherwise, it would have said increase the dose. So you're always assuming in these trials that you're giving it at least enough time to make sense. So 8 to 10 weeks. I guess that makes sense. Okay. All right. So again, this is so we know that how important it is for the patient to actually have some power over their own treatment. So this is the CAP score during the acute phase of treatment with prolonged exposure versus paroxetine. And we can see the placebo versus the paroxetine. The paroxetine actually was effective in, so this is the prolonged exposure with the placebo or paroxetine. Excuse me, I hope I'm saying that right. So the placebo plus prolonged exposure or paroxetine. So in this case, the placebo actually has a higher score. So we can see that the paroxetine was helpful. Sorry that I confused that a little bit for you. That makes sense? Okay. Was this providers rated? I don't know. I'm sorry. I've got the, I don't remember if it was or not. So this is, was probably not, would be my guess. But I don't know. But the citation is there. And I can answer, I can find that out for you if you want. So if you still want the answer to that, I'll go look it up. I just, off the top of my head, I can't remember. So let's look at treatment guidelines. Again, there are going to be views on this. If you're in an agency, it's going to be different, but this is in general treatment guidelines. So APA believes that if you treat trauma, you should be trauma trained. And I agree with this wholeheartedly. I think there are many people who are not trauma trained that do this sort of re-traumatization. Sometimes it's not, you know, within their control. For example, if they only allowed one session with a patient, you know, it's very hard to not re-traumatize, but you need to have some specialized trauma training. In general, you want it sort of an eclectic, individualized pace to patient tolerance. So if you're doing manualized treatment, which, you know, is good, you still can individualize it within that because they're going to have different sorts of subsets of symptoms. You want to have both top-down and bottom-up control. So they learning some sort of way to regulate themselves both in and out of session. So one of the ways you can re-traumatize patients is to have them in session with you and recounting the whole trauma without managing the stimulation, as Dr. Papp talked about. And it's really, you know, sort of a brain organized response if you get them too stimulated talking about the trauma. And of course, this therapeutic alliance is critical. I think it, in my opinion, is probably more critical than in some other sorts of presentations. And then the medications are going to target the subsets and specific symptoms of the disorder. And of course, you treat the co-occurring disorders. And my caveat is always, whatever you're doing, you don't re-traumatize the patient. This sort of suggestion comes from the same group from the VA that gave this meta-analysis that I talked about at the beginning here. So Murray Stein and Serene. So the patient presentation at the time is going to influence the kind of psychotherapy that's going to be used. So they suggest that if there's extreme fear and avoidance, that exposure techniques that would be helpful. Exposure techniques would be particularly helpful. Guilt and trust issues, cognitive therapy with exposure therapy. If they have difficulty engaging emotionally, VR exposure. I do virtual reality myself, and sometimes it is extremely helpful for patients who are unwilling to do it by themselves. And if they're unwilling to accept exposure-based therapy, some sort of interpersonal therapy. And if the patient's clinical presentation doesn't emphasize one of these symptom clusters, then therapy availability and patient preference typically determined. So sometimes this just isn't going to be possible. I mean, particularly virtual reality, that's not going to be a possibility for a lot of people. This is sort of what do you use a virtual? I do use a virtual reality system. I use the SIAS system. Which I find very effective for phobias. I treat more phobias. PSIOS, P-S-I-O-U-S. It's a system from Spain. And there aren't many PTSD sort of situations in it, but I modify it. And it's amazing that when you put somebody in the system, even though they know they're in virtual reality, that amygdala just lights up and they're there. So I find it very effective myself. So this is a sort of phased treatment that you would do for treating PTSD. I have to emphasize again, everybody does a little bit differently, but in general, this sort of approach can be helpful. And just because it's sort of sequenced, it doesn't mean you can't skip parts and move forward. But in general, processing the memories at the beginning of treatment is not going to be a good thing. So you want to have this external control, so unpredictable danger to reliable safe. If the patient doesn't feel safe within their current environment, it's going to be difficult to reduce those PTSD symptoms. Given this internal control, self-rescue skills for intrusive symptoms. So I do a lot of physiological sort of work in order to reduce their reactivity, certainly their cognitive techniques as well. You're going to normalize experience and educate, give them resources, all that kind of stuff you do with most of your patients. And you're going to think about the physical issues in self-care. And this is where the medication, again, is going to come in a more clear way, that the medical referrals and medications to treat the specific symptoms. And in particular, there's going to be sleep issues, substance use, and nutrition you're going to see more often, and exercise. So sleep, nutrition, exercise, and substance abuse, you can't really underplay in this population at all. They need to be treated with specific things. I have tons and tons of notes on this, and I'm not quite sure how much time we have. Plenty of time. So when you first, okay, let me continue on. So then you're going to develop some sort of emotional regulation techniques for the patients and do awareness. So particularly if they're dissociative, they can stay within, stay within the clinic room without floating away. You're going to help reframe their post-traumatic growth, process the memories. And in some cases, I mean, particularly for patients, at least in my experience, who have complex traumas from early childhood, sometimes you don't even want to go into those because they can bring stuff up, and if the patient is doing well, then it can be kind of destabilizing for people. So somebody posted something, if there's something, a free download for something. I'm not sure what that's about. But if you want to tell us what it is, that would be great. So acute part of the trauma, it's really when you first see the patient. So you may not see an acute phase of the trauma. It may just be, when you first see them, they're still in an acute state. This critical incident debriefing is not effective. Yeah. I see it's about the PSIOS program. Good, thank you. Exercise, there's a potential mechanism for which the aerobic exercise can exert a positive impact on PTSD, including exposure and desensitization to internal arousal cues, enhanced cognitive function, exercise-induced neuroplasticity, normalization of hypothalamic pituitary axis function, and reductions in inflammatory markers. So exercise can be very helpful. What I find is that for people in very acute stages, sometimes exercise that gets the heart rate going can be counterproductive because they start getting sort of a traumatic presentation from it. So that I believe that exercise needs to be, there needs to be some exposure therapy done with exercise, so you don't reactivate people. Part of this emotional regulation, you've probably all done sort of some grounding work. Establishing a routine, I think is always part of it, and that's going to help with the sleep, nutrition, and exercise. Again, we talked about sleep as being, and weight loss as being markers where you really want to have some intervention. So of course you always want to try the more therapeutic techniques for sleep. So CBTI, I've been trained in, but I rarely use it on a PTSD patient because I think it's fairly aggressive. I think more sort of softer approaches or modified CBTI is helpful. There's fear of falling asleep for some people, but you want them to sort of limit the naps, limit how much medication they're taking for sleep at first, regulate their schedule. And then with the weight loss, what I find is that just calories. So people have trouble maybe eating their normal diet, and soft foods may be easier for them because there can be some constriction in the throat because of the sympathetic response. So just trying to get them to eat something to keep the weight up rather than any sort of strict nutritional codes at the beginning. And then exercise. Yoga now is actually really considered to be one of the treatment of exercise choices to help with PTSD. And then limiting substance, of course, is like alcohol and stimulants. So for people who have a potential alcohol problem, I'm really clear. I go, this is not a good time to increase your alcohol content. In fact, this would be a good time to not drink anything at all, because I think that can easily escalate for people at this time. So I warn them sort of upfront that this is a good time to be abstinent if they can, or if it's appropriate for them. Certainly not somebody who's a high drinker, you're going to take off right away, but there is a potential for that increase at this time. So are any questions at this point? Okay, let's go on to sort of a little more detail about this. So the medications to target the PTSD symptoms. Here are the key things you're going to target with medication. You're going to target the re-experiencing, avoidance, numbing, hyperarousal, and insomnia, negative cognitions, and mood. Well, so if you're treating like in this treatment model where you're doing SRIs, clearly the antidepressant hopefully will treat the negative cognitions and mood. But then there are specific medications that are going to be treating these other symptoms. So I'm just going to go through a few of the presentations about sleep and substance use. So the reason we spend time on it, because the sleep it's sort of bidirectional. So sleep issues are a symptom of PTSD, and actually they're a generator of PTSD. So it's really important to get those under control pretty quickly. So insomnia, really common, either initiation or maintenance, or this early morning awakening I see often. Nightmares, fragmented REM sleep are predictive of developing PTSD. So PTSD has a dampened REM state, so they've got nightmares, but not necessarily a lot of dreaming. And so this is particularly in vulnerable adults who have prior sleep issues. This is going to be predictive of them of actually developing PTSD after the trauma. The quantity and the quality of the sleep can be disrupted after trauma. So don't just think about hours that they're sleeping, think about the quality. Are they waking up every 20 minutes? Because if they're waking up every 20 minutes, they're not getting a full sleep cycle. So the acute post-traumatic insomnia, so we're just talking, fairly immediately after the trauma, disrupts the sleep-dependent emotional memory consolidation. And the post-traumatic insomnia can be chronic. So there's this memory consolidation that happens in REM sleep, and with PTSD, when that's disrupted, it's not helping to consolidate the memory, to process the memory properly. So the chronic sleep disruption perpetuates the PTSD symptoms. The symptoms can worsen over time. The sleep disruption maintains and exacerbates the symptoms. So again, it's not only a symptom of the PTSD, it helps maintain the symptoms. Continued interference with normal processing of the emotional memories if they're not getting enough sleep. At night, they're not processing them. Then their day, they're too tired. They can't really process them. This impaired consolidation of memories yeah, did I spell it? I think I spelled that right. Memories and extinction of memories with exposure therapy. So it's not, if they haven't slept, they're not really getting extinction of the memories even with exposure therapy. So again, the mechanisms I think is that this REM sleep that is disrupted in PTSD is associated with consolidation of emotional memory, and you have it dampened in PTSD. There's also a potential neuroendocrine response, stress response, and sleep disturbances can produce sort of a synergistic effect. One thing completely this is not at all something I've read about. I've just experienced it. Patients, sometimes they have no REM sleep with PTSD, and they take a little bit of melatonin they get, which is REM producing, and they get REM sleep back. So again, don't quote me on that. So sleep paralysis and PTSD, any relationship? I have not read about sleep paralysis. Let me just check with Dr. Pat. No, he's also shaking his head. I know there's sleep paralysis with some medication association, but I don't know about PTSD. Does anybody else know if there's an association with sleep paralysis? Okay.
Maybe the nightmares.
The night bears. I've had 3 cases with this. Well, so yeah, I haven't heard, and Dr. Papp doesn't mean it doesn't exist. I think that's the main thing with psychiatry, is that anything can happen to, I mean, I never rule out anything, particularly with PTSD. I don't know what's in the literature, people who have been trapped, etc. Huh. Well, that's interesting. I'm going to go look it up myself. I think it's more often when they have awakened from nightmares and are still atonic. Yeah, that makes sense to me. So sleep paralysis is a really specific sort of thing. They're awake, they can't move, their eyes are opening, and yet everything's sort of paralyzed. So that would make sense to me. I'm going to look it up afterwards. It's very interesting. If anyone else finds out about it, please let me know. So, okay, so here's sort of summarized. The sleep and how it works is the traumatic event happens, acute stress response with acute insomnia. So at the beginning, they're not sleeping at all. And if you get back into a normalized sleep patterns, you sort of resolve the acute response, and you can go back to PSD, you can go back to sort of a normal sleep response. And this normalized sleep is going to happen either with medications or not, but this is more the arm that would say that this is just going to be normalized. But if there's this acute insomnia, it turns into chronic insomnia. And then this sort of sleep-dependent consolidation and generalization of extinction of habituation is disrupted, then it's going to provoke more insomnia. And you get this really PTSD-specific sleep disturbances and sort of a cyclic, cause and effect thing. And so you can treat before it develops into chronic insomnia, you can treat it here and also down here for the PTSD specific sleep disturbances, and that would generally be prazosin. Are there any questions about sleep? More. Okay, Dr. Papp will probably talk a little bit more about treating sleep. So again, this is sort of more of a treatment overview, so he can go into the specifics. And we'll take our break at 10 of. So here is a recent review of sleep paralysis and trauma is suggested. Here, terrific. I will look at it. I just had not had any patients with her or read any particular article. Okay. So we talked about substance use disorder. So PTSD commonly occurs with substance use disorders. Estimated prevalence is about 42% with PTSD in general population, but 55% in veterans. So that's a huge number. The odds of PTSD are significantly greater if you've had an alcohol use disorder. So these are big numbers. Among veterans, 63% met the criteria for PTSD, and 76 with PTSD met criteria for alcohol use disorder or substance use disorder. So again, my general approach is to first of all warn people that if they suffered a trauma, that then they're more susceptible to developing a substance use. Yes, alcoholic water in the military, absolutely. As far as I know, in the law profession as well, but it's just my experience. with patients. So here's some proposed mechanisms of substance use disorder and PTSD, the correlations with it. It's really a complex interplay of factors that's going to feed this comorbidity. They're biological factors, neurotransmitter, environmental and psychosocial. So it's pretty complex in terms of what's happening, this sort of bidirectional approach, which is making which worse. And then it's recommended to treat PTSD and the substance use disorders concurrently. There's going to be variation in that. I mean, there's controversy on both sides, say that substance use first and PT, but in my opinion, you treat them at the same time. Here's one example, this concurrent treatment of PTSD and substance use disorders using prolonged exposure therapy, and I believe that is from the VA, so it's just one example. So I believe in treating them together. So the somatic complaints are very common within PTSD. So chronic pain, which is going to be part of this, is presentation. It's a nociceptive memory and results from significant functional and structural changes in the nervous system similar to memory processing. So this pain is really processed as a memory, and the persistence of the memory of pain or the inability to extinguish the memory of pain evoked by the initial and inciting injury is part of the chronic pain scenario. So if there was pain at the time of the injury, time of the trauma, it's going to be part of when you start thinking about it, it's going to evoke the pain. So I forgot to put down in the slide that it's not just this chronic pain or pain that's associated time of the injury, but there's this more diffuse pain that I think a lot of people with PTSD suffer, just strange somatic complaints and tingling, and I'll talk about stomach hurting and things like that. So it's pretty common, this sort of somatic complaints. Is that what other people experience in their patient population? Yeah, so it's hard to treat. Yeah, everybody's got it. So I do a lot of just that. Yeah, headaches, stomach aches, body aches. Yeah. Okay, so here's sort of a clinical summary. So psychotherapy is absolutely essential in the treatment of PTSD. It is first line. So the evidence-based psychotherapies that are trauma-focused have the largest effect size, have larger treatment effect sizes than antidepressants. So this is one of those situations you don't reach to medication first. Antidepressants can reduce the PTSD symptoms, enhance quality of life and functioning, but they're only 2 right now that are FDA approved, but the sertraline and venlafaxine actually have the largest effect sizes of medication studied in PTSD. So sertraline and paroxetine are the 2 that are FDA approved, but sertraline and venlafaxine have the largest effect size. And again, that doesn't mean you can't use other antidepressants. So if they're already on or have taken Lexapro in the past, there's no reason to particularly switch them to something else, but Dr. Papp will talk about that. So the combination of psychotherapy with antidepressants may be more effective overall than either alone, just like depression, like almost anything else. More studies obviously are going to be needed to confirm that sort of clinical impression. So we've got a question. That is why we do IND trauma-focused IBP in the PCT. Well, that's way too many letters for me. I'm not sure what that all means, but oh, there, you did fun with that alphabet soup. Okay, good. I thought maybe I was supposed to know that because I didn't. So first of all, I'm going to go back to the case of Susan for a few minutes, but I want to ask if there are any questions about anything I've talked about at this point. Okay, so let's just finish here with the case of Susan. So here's what happened to Susan. Her primary care physician.
Wait and then go after the break. It's 5 minutes.
Yeah. I'm just going to go ahead and get you started here, and then we'll finish it I won't have time to finish it before the break, and then we'll just finish it. So Susan, do you remember? So let me scroll up to the top again. She had, so I am using a mouse. I'm not used to it. Okay. So she had this crisis session first. And then her primary care physician prescribed by phone lorazepam, remember? This huge dose of lorazepam. She's screamed less, but was more disoriented. And then, so what went wrong? So misdiagnosis, re-traumatization, no comprehensive sequent treatment, potential medical issues weren't addressed, prior mental health conditions, inappropriate medications, lorazepam at high doses, multiple providers with retelling, and no known resources and support. So we're going to come back and we're going to talk about how you would have treated her. So we're just going to end a few minutes early because I'm going to want responses from people about what they think the treatment should have been. So maybe just review just for 4 extra minutes the treatment protocols we talked about, so we know how to treat Susan. Does that make sense? Okay, so please come back in at what is that going to be? 2 o'clock. Thank you. Susan. So I'm going to just leave her case here, and I know it makes it, the slides are a little smaller, but the slides aren't as important right now. So, so we know what went wrong. So let's talk about treatment. So we know at the first off that first responders refer to community. We want to get her some help in the community. So survivors of suicide loss or some sort of support system, not alcohol at this point, but something to get her out into the community. Okay, the next step would be, so that's sort of something that we're all going to do anyways. So what would people suggest for medical referrals for her? Because remember, we always want to try to refer out for things that are beyond our scope of practice, that might need help with. You see in the scenario that might say she needs some sort of medical referral. We certainly got social work, but how about medical worker, medical referral? PCP, so why would she go to a PCP? What would be the indication? Or what would be your, in the scenario, what would point to primary care? Know her history, good. Yeah, so they might know that she's got alcohol potential and what her past is. No, so there's something within the case. So what do we see at the very beginning? It's kind of tricky, this. 3 weeks ago, we found her husband hanging. Okay, Susan's neighbor found her on the floor next to the body, barely responsive, a ladder fallen by her side. So what happened? Like, we don't know. At this point, potential for a head injury, absolutely. So she could have, fainted from the, had an incident just falling. She could try to help him. Remember, he's hanging from the living room ceiling fan. So we don't even know if there's a medical injury at this point. There could have been a concussion. There could be a serious head injury. Anything else? So later in the scenario, not at first, but what else might we see that would say that she might need a medical intervention? So how about the next to last paragraph? She's not eating. I assume the latter was his. PCP probably is to cover all our bases. Yeah, so PCP would be good. I mean, absolutely. You don't need to refer to a specialist for the head injury. You just don't know. So yeah, primary care absolutely knows this history. Yeah. So in the last paragraph, you also see she would not eat and barely drank liquid. So she's beginning to become dehydrated. So I would say that's absolutely a medical referral. And also, she's unable to read or maintain focus for longer than a few minutes. That can be part of the PTSD, but it could also be medical issue, right, if she's had a head injury. So we would need to rule out head injury or self-injurious cause. If, why is she actually unresponsive by his side? That's not, a typical sort of PTSD presentation. Not that would never happen, but not typical, but it could be. So she's also dehydrated, she's not eating, and she's got this cognitive decline. We got to make sure this patient is actually medically sound. So if I saw this patient, I'd absolutely say, you need to go get checked out by your primary care, see what's really going on, get for the dehydration. So does that make sense? Okay, so let's go on to therapy with the trauma-trained professional. So clearly we need to get this woman into some sort of therapy for the trauma. I don't no particular choice in here, but whatever would work or it's available for her. Let's talk about medications now. So we've mentioned just sort of briefly some of the medications that are going to be used with PTSD. Dr. Papp's going to go into it more. So first of all, we know what the wrong medication is, right? You're not going to give 2 milligrams 3 times a day lorazepam for, first of all, it's not grief. She didn't have a proper assessment, but actually lorazepam. So the benzodiazepines, generally the course is worse with the benzodiazepine. So she's not going to get no benzos. That's right. So if there's a benzo used, it would be very briefly, but even then it's not particularly appropriate. So what would be appropriate in your case? And what are the reasons for that medication being appropriate? So let's get some ideas here. Escitalopram. So if she was on escitalopram before, it's a good one to be for. It's not the ones that are FDA approved, or right? So sertraline, venlafaxine, absolutely. Anything else? Okay, what might you give for, she seems like she has some hypervigilance and she's having some nightmares or sleep issues. Does anyone know what you might give for that? Yep, prazosin, absolutely. Good old prazosin. So there are some other medications that might be helpful with some of the activation, but prazosin is generally the first medication. How about this hallucinations? Would you give anything for that? She had hallucinations of her dead husband. Second generation antipsychotic consideration, absolute consideration, because with grief, there can even be kind of sort of hallucinations, which are transient. So it really depends on the level that the hallucinations are. So let's look at the answers to this thing. So I would want to differentiate hallucinations, intrusive thinking. Right. Seeing the dead after loss is not abnormal. Well, that's what I said. So it is not abnormal to see. It sort of depends on the level. So even with normal grief, you might have hallucinations of the lost one. But if we're really talking about sort of hallucinations that persist, we're talking more sort of the psychotic edge to it. So that's where you'd have to make an assessment and really understand. But clearly this is not, clearly this woman is not suffering from normal grief. But it would be something you'd have to, to have pretty careful monitoring. So the hypervigilance and sleep issues, the prazosin is going to be first choice. Sleep and appetite. So if she continues to lose weight on a short-term basis, you're going to think about something like quetiapine, which also has a little bit of antipsychotic piece to there. You get nice low doses for it, give it to her at night. So that's going to add, are we still within 1 month of suicide? I believe we're after 1 month, right? So 3 weeks prior found hanging. So 3 weeks prior, no. So she's not actually diagnosed for PTSD even at this point, but it doesn't matter. She's still got the symptoms. So if she's hallucinating and so it doesn't mean they're necessarily going to resolve. You can still treat. Does that make sense? Okay. So, okay. So remember, you want to try to treat early with PTSD, get them in, and so that the symptoms don't consolidate, they don't get worse. So you could use, again, back to sleep and appetite. So quetiapine would hit both of those. Both of the kind of psychotic elements too, but sleep and appetite, so people get hungry, and quetiapine, Seroquel. And then there's mirtazapine for sleep and appetite. People gain weight on this is Remeron, they gain weight, but you've got to keep it in low doses. Very important to keep it low doses in order to get that sleep effect. You could add maybe some gabapentin that would help for sleep and appetite. A little bit of weight gain with gabapentin, not much, but it sort of dampens people a little bit. Trazodone's a possibility, but my choice would be probably mirtazapine. And then with mood anxiety, if she has a history of mood disorder, so you're going to treat as soon as possible with an SSRI. So you mentioned Lexapro, which would be appropriate, but here are the ones that are approved by APA and which have more, they're the ones that are starred, but these 4 are approved by APA. There's FDA approved as paroxetine and sertraline, but all 4 are APA guidelines. But if she's already got a mood disorder, a history of mood disorder, remember with depression, the chance of relapse is high. So you would want to treat early. If there's no history of mood disorder, and if the mood is worsening after 2 weeks, then treat with an SSRI. So if this was at the, after only 2 weeks you saw her, then, you might want to wait to see if there's, and you can, certainly the choice between, a therapy versus SSRI, you could still make if it was fairly early in the treatment. But if it was me and I saw this patient, at the end of the scenario at this 3 weeks, I might consider inpatient stabilization to begin treatment. This is a very compromised individual from all sort of aspects. We know from that, so she suffered a suicide, so she's going to be at more risk for suicide herself. She's not being able to take care of herself. She's got alcohol, so a very compromised individual. So are there any questions on this? And then, yes, inpatients. So that would be if you got her at the end of the scenario, I would do inpatient if possible. So just get her stabilized. Any questions about this at all? Make sense? Okay. Nope. Okay. So we're going to turn it over to Dr. Papp and leave Susan to and this patient got better. Just so you know. There wasn't inpatient, unfortunately, but it took years, even 6 years later, there's still symptoms, but she got better. Okay, thanks. Turned over to Dr. Papp now. We just have to take a minute while we're getting the slides back up, okay?
I apologize for this little glitch here. Am I being heard?
Yes, sir.
Okay. So let's talk about the pharmacotherapy of PTSD in detail, which is sort of like a very sobering exercise for me after hearing about all the effectiveness of psychotherapy and knowing that pharmacotherapy is really not the best treatment, not the most effective treatment for PTSD. Even in the study Dr. Myers mentioned showed that there was no statistical difference between sertraline and prolonged exposure therapy, but there was a difference in the endurance of the effect. The prolonged exposure, the effect of that treatment lasted longer than the effect of medication. So definitely that's the most effective treatment if everything else is considered. Having said all that, for practical reasons, pharmacotherapy is often the most readily available treatment option or option preferred by patients. It is because it is cheaper. It's all you need to do is pop a pill and quote unquote forget it. But insurance companies certainly would prefer 15-minute psych medication visits every 3 months versus weekly 1-hour psychotherapy sessions. Also, as Dr. Myers mentioned, there's people preference differences. Some people prefer psychotherapy, some people prefer medication. And experience shows that war veterans is the population that is most likely to resist referral to pharmacotherapy. It's not only that, but compared to other diagnostic categories, PTSD has really an inferior selection of evidence-based medication therapies. There's no clear phased treatment protocol, such as the STAR-D in depression. The algorithm that Dr. Myers presented is the result of a meta-analysis and not anything comparable to the STAR-D. Meta-analysis, even the number of them is much less than the meta-analysis of depression studies. And these are the findings. There's fluoxetine, paroxetine, and venlafaxine in multiple studies. Amitriptyline, mirtazapine in, sorry, I just need my little. Mirtazapine, amitriptyline, and phenelzine in a few studies, and in general, SSRIs as a class over non-SSRIs. There's something called the PTSD psychopharmacology working group, which a few years ago put out a crisis statement. And these were the basic observations that, as opposed to many other conditions, only 2 FDA-approved medications exist, and they have limited efficacy. There's been nothing new approved, pretty much almost in the past 20 years. The first randomized controlled trials in PTSD were conducted in 1988, compared to depression, which goes back to decades before that. Because of all this, basically an ad hoc, what I could say, hodgepodge polypharmacy. That is the most common type of treatment in PTSD. And all those nice things that I mentioned to you, about
Sorry about that.
okay, 1 second.
They don't see it.
question. With so many PTSD patients suicide, why do you think there are so few studies? Because the diagnosis of PTSD has not actually been accepted until the late 1980s. When I did my psychiatric residency starting in 1988, 1987, there was the first ever book that came out of PTSD, and that was not even a book that was based on any clinical studies. That's when the diagnosis was first even brought out into the consciousness of the profession. So there simply was not, there's no diagnosis. There were other diagnoses like, I forget the names, different names of addressing war traumas, but PTSD as a general disorder related to any kind of trauma, not just war trauma, has not been really ascertained or recognized as a separate entity until the late 1980s. It's pretty amazing, but that's the reason why. So there were no studies because there was no diagnosis. Yeah, battle fatigue was one of them. The First World War, there was something else. Maybe somebody can find it. Shell shock, that's right. That was First World War, shell shock. And after Second World War, there was battle fatigue. So those were the diagnoses. So there was not even diagnosis, there was just terms. So the diagnosis of PTSD is one of the newest psychiatric diagnoses. And finally, there's no translation of new finding in neuroscience into clinical practice. All those nice things that I mentioned about the Broca area and the medial prefrontal cortex and the amygdala, at this point is really just theoretical. I mean, we know that, but there is no medication treatment that is based upon that. So let's talk about the treatment of PTSD or the prevention of PTSD in terms of the concept of prevention. This primary prevention, of course, which would simply mean that you don't get yourself in a situation that is trauma. The secondary prevention is to prevent the development of the disease after, in this particular case, the acute stress disorder after trauma. And because of the nature of PTSD and all these structures involved, certain kind of medications have been tried. So hydrocortisone was tried to address the role of the hypothalamic system. Propranolol was tried to address the epinephrine system. Escitalopram, of course, tried because you tried SSRIs for everything pretty much, benzos as well. No evidence. Oxytocin, there is one study that has been underway for the past several years. I'm following it, but no results have been published yet. And ketamine, there was a case study that I mentioned already, where the children who were in the burn unit developed less PTSD who got ketamine right after the burn occurs. So these secondary prevention measures would be administered within 24 hours of the trauma with the goal of preventing the development of PTSD later. None of these studies really panned out, and none of these studies have been put into, effect. Most trauma survivors will not develop PTSD, so it is hard to know who to interview with. Well, that is also true, but again,
vulnerable individuals.
But theoretically, probably there is not much damage to do with secondary prevention. So if somebody would not have it and you do secondary prevention measures, probably nothing wrong would happen. But theoretically, if somebody is a vulnerable individual, then you might be able to prevent the PTSD. And also, you can assess vulnerability by assessing previous risk factors. So somebody who has already been traumatized, somebody who comes from neglected environments. So those people would be more of a high risk, and maybe you would select these secondary prevention measures with them. Pharmacological treatment proper, which is sometimes called tertiary prevention, would mean that you start treating the disorder when it appears to prevent it from becoming worse. As Dr. Myers mentioned, you should start treatment optimally shortly after the diagnosis is made. If you do early treatment, any kind of psychiatric, in case of any kind of psychiatric illness, it may prevent chronicity. It has not been shown empirically regarding PTSD, particularly for pharmacotherapy, probably more likely for psychotherapy. But nevertheless, there's no reason why you should not start doing it as early as possible. As Dr. Myers had mentioned, sertraline, paroxetine are the only FDA-approved medication, and SSRIs as a class are recommended by practice guidelines. However, in clinical practice, any medication with an antidepressant effect that depends on serotonin can be justified. So it can be an SSRI, can be an SNRI, can be a TCA. There's no reason why not. Serotonin is serotonin, the serotonin reuptake inhibition is serotonin reuptake inhibition, whatever, no matter what the medication is. I would still think that because of all the things I mentioned regarding escitalopram being the SSRI with the least amount of side effects, the least amount of interactions, with a treatment-naive patient, I would still recommend to use Lexapro as the first, escitalopram as the first choice, even though it's not formally approved, but at least it's in the SSRI class. In general, the individual differences in response to pharmacologic treatment outweigh treatment-specific differences. So basically, you keep trying until you find something. You, of course, start with what is most likely recommended. You go down the algorithmic pathway, but eventually there will be no choice that is within the algorithm, and then you would start making your own choices based on a variety of factors, which will be tolerability, which would be comorbidity, which would be patient's preference, etc. And as far as which medication is more likely to work, there are very few individual predictors that are available. So what can and what you cannot treat with pharmacotherapy? What is that response? What does not respond to pharmacotherapy? So study shows that certain features, certain symptoms of PTSD produce reliable effect. Some features may or may not have effect. Studies are not that hot on that. And there are a few features, a few symptoms of PTSD for which there's really no established pharmacotherapy. Again, it doesn't mean that you won't try something, but there is no established pharmacotherapy. So we have established pharmacotherapy for hyperarousal, hypervigilance, irritability and anger, and in general, of course, mood. That is the one that provides an antidepressant effect. there is established pharmacotherapy, but no reliable effect, which means that there is no statistical evidence between large-scale studies that would show that there is efficacy, is improving sleep. So again, there is a lot of ad hoc treatments and individual differences in the providers, whichever medication they like or not like, in terms of what they use for improving sleep. It doesn't mean that there's no reliable effect. You can finally find something that's going to work with sleep, work for sleep, but there is no studies behind it that you could quote that, okay, this is why I'm using this and not something else. And the same is regarding phobic avoidance. And there's a very poor response to pharmacotherapy in dissociative symptoms and decreasing of emotional numbing and the sense of foreshortened future, which seems to be a little bit different from hopelessness that is an antidepressant, sorry, it's a depression symptom. One of the problems with emotional numbing is that, let's say you would treat a PTSD patient with an SSRI, and one of the potential side effects of an SSRI is emotional numbing. So it is, again, a conundrum. These are the major drug categories. We have the antidepressants. We have the antipsychotics, the sympatholytics, both alpha and beta adrenergic. All the others, which is a huge category, the benzos, the mood stabilizers, the cannabinoid, the NMDA modulators. And there are the gray area agents, which have been coming up in the past, really just very short, very low number of years, maybe last 1 year, I would say, maybe 2. And these are the gray area agents. I call them gray area agents. And these are in the increasing level of grayness would be cannabis, MDMA, and psilocybin. And I'm going to talk to them, not because it's likely that you're going to use them in your practice right now, but because it's possible that you're going to use them in your practice in the upcoming years or perhaps decades. So here are the SSRIs. Everything I said about the SSRIs in the depression lecture is applicable. There is nothing specific about the SSRIs that would be specific to, there's nothing about the SSRIs that would be specific to PTSD. So all the side effects, all the usage rules, all the considerations, interactions, etc. apply. You start low, you go slow, you probably have to go higher than in depression. You go at least 6 to 8 weeks before you declare a trial to be a failure, probably even more. And this will be an example. So let's say you start a patient on sertraline, either at 25 or 50 milligrams a day. I like 25, just because there's no reason to start at 50. And then start increasing the dose, every 25 to 50 milligram increments every 2 to 4 weeks, maybe even faster, up to 200 milligrams per day, which is the FDA approved maximum. And if you're brave, you can go up to 250 milligrams. I have seen someone on 300. There was a patient who was taking 400 milligrams by mistake, and there was, no problems. Actually, let me tell you something about these medications. These antidepressants, when they do clinical studies, they study them in really, really high dosages. So just happened to read recently that the study about duloxetine Cymbalta. So the maximum dose the original maximum dose by the FDA was 60 milligrams. Eventually, because it was clinically not effective, it went up to 120 milligrams. But in the safety studies, they studied duloxetine up to 600 milligrams a day on people for several weeks, and nobody had any problem with that. So believe me, these medications are probably even underdosed according to FDA. So you should never be hesitant to go up to these upper dose levels if you want. And you know, again, if you're brave, you can go up a little bit higher. And again, you would use the same example with any SSRI if you want. I would caution against using paroxetine because of all the side effects, even though it's FDA approved for PTSD. Sertraline should be probably your first choice if you want to go FDA. If you want to go, just go on safe on side effects, then start with escitalopram. But with the Prozac, you can do the same with Prozac. Again, the problem with the Prozac that sometimes in the first week it may cause some overactivation, which may not be the best with someone who has like an activated kind of PTSD. SNRIs, you can use SNRIs, people who have PTSD with pain symptoms, because as you know, SNRIs can be used for pain, so duloxetine would be especially preferable for, let's say, a war veteran who has who suffers some kind of a trauma, physical injury trauma, besides the psychological trauma. So you can sort of like kill two birds with one stone. But again, the way you would use duloxetine in PTSD is exactly the same you would use duloxetine in depression. So here it is a little about the SNRIs. There were some, again, very few. I mean, just compare these numbers to the number of studies that are done with depression. It's just ridiculously small. And again, don't forget that much of these studies are done with by drug companies. Drug companies will do studies if they can bring to market a new drug. There's nothing to bring to market. Therefore, there are no studies in PTSD by drug companies, no studies about these drugs, even though they could be clinically useful, whereas nobody's going to do them. There's no money for it. And I said there's no studies on duloxetine or milnacipran, but they can be clinically justified. Just as in depression, they could be clinically justified. Mirtazapine and nifazodone. Just like in depression, you can use these medications to treat the underlying condition plus comorbidities. So you would use mirtazapine, as Dr. Myers mentioned in the Susan study. For instance, somebody who is not eating and can sleep, this would be a very good first choice. But you can use it as a second choice antidepressant. So let's say you fail an SSRI. After, let's say, 3 months, you can switch to high dose mirtazapine. Same for nifazodone. Again, don't particularly be afraid of nifazodone. It's a very good medication. Again, one of the things that you may remember from the depression lecture, that it does not interfere with REM sleep, doesn't suppress REM sleep. Therefore, if it stops REM rebound, which is very important, somebody with PTSD, let's say, stops the medication and then suddenly the nightmares just get blown out of proportion. Trazodone. Trazodone is one of my favorite medications to love and hate. It can be a very good medication, but again, don't forget that it has a particular proclivity to cause problems in people who are CYP2D6 low metabolizers, especially if they at the same time CYP3A4 high metabolizer, but that's not necessarily. If you are CYP2D6 low metabolizer, and it's not that rare, then this toxic metabolite MCPP can accumulate, and it can really worsen hypervigilance associated symptoms in PTSD. I have seen it myself. gave it to a patient, and came back next time, throwing the bottle at me and said, "Don't you ever give this medication to me." He took it, and his nightmares got worse, and his hypervigilance got worse, and he had a very few bad days until the MCPP finally cleared out of his system. So consider that when you give trazodone. I would suggest you should never give trazodone in a high dose. You should start trazodone at 25 or 50 milligrams just because of that particular reason. Okay, second generation antipsychotics. Randomized clinical trials provide limited evidence of efficacy. There is one trial on quetiapine monotherapy. And again, don't forget, quetiapine has some serotonergic effects. It's not a reuptake inhibitor, but it's a serotonin modulator. So that's maybe one of the reasons why it is helpful. So it can, in that particular study, it showed an improvement in the overall score on the CAPS and on the re-experiencing and hyperarousal subscores compared to placebo. So quetiapine, again, in a low dose is a pretty good medication for PTSD sufferers. Probably I would not start it as a monotherapy, except if somebody has the biggest symptom is sleep, and the mood symptoms and other symptoms are not that prominent. Then a very low dose quetiapine, like 12.5 or 25 milligram, might be good as a first choice, but probably you don't want to use it as an add-on. Risperidone augmentation has been shown in a trial. Found small reductions in re-experiencing and hyperarousal. Second generation continued. So aripiprazole has been studied both as a monotherapy and augmentation. It has shown improvements in anxiety, avoidance, hyperarousal, flashbacks, and sleep, and positive effects on mood. Again, I mentioned it with the depression lecture that aripiprazole is probably one of the best augmenters of the antidepressant effect, the serotonin effect, more generally speaking. So probably that's one of the reasons why I would say that you could consider aripiprazole in a PTSD patient. Again, I would not use it as a first choice, but if you have trouble with the antidepressant, with the serotonergic medication, you would then add some aripiprazole. There was a single study on olanzapine, which showed clear improvements. In a case study, it actually showed improvement over fluphenazine, which is the first generation antipsychotic, in the treatment of psychotic PTSD. But again, I would suggest that you should not use olanzapine, Zyprexa, unless there's really nothing else. The metabolic side effects can be scary. You don't know, people can gain huge amounts of weight on olanzapine, but even scarier, you don't even have to gain a pound, and you can have clear metabolic syndrome. I had a patient many years ago. He was on olanzapine, and he was skinny as a rail. And just for the heck of it, I did the metabolics, and everything was off the chart. And he just didn't gain a pound. So we have to be careful with olanzapine. And others, asenapine, which is Safris, and just a few days ago, a patch came out. So now it's available as a sublingual pill, as in a patch. Ziprasidone, iloperidone, or Fanapt, again, because I think I mentioned it that the depression section, iloperidone is it has a special secondary characteristics that besides being anti-dopaminergic agent, it is also an alpha-1 agonist. almost as strong and maybe as strong as prazosin, which I'm going to be talking about soon. So theoretically, this would be a good medication for PTSD with some psychotic features. There was a hyperarousal study, which I know that started out, and I have never found the results, so it probably was negative. And there is no studies with these medications except that brexpiprazole, which is Rexulti, had some animal studies in models of PTSD. What's the model of PTSD? Animal study model of PTSD is predator stress. Okay, any questions before we go on? No, so let's go, there's a little quiz, and after this quiz, we can take a break. Which of the following, okay, now I can read. Which of the following does not reduce the activity of the sympathetic nervous system? A beta receptor antagonist such as propranolol, an alpha-1 receptor antagonist as prazosin, an alpha-2 receptor antagonist as yohimbine, and an alpha-2 receptor agonist as clonidine. Okay, so we have 80% voted. And yes, an alpha-2 receptor antagonist such as yohimbine. Why is that? Because an alpha-2 receptor is what kind of receptor? Okay, so now let's see. So the alpha-2 receptor is a presynaptic receptor which has an inhibitory effect on the postsynaptic membrane because of the inhibition of the synaptic bouton. So if you inhibit, the inhibitor obviously is going to excite the downstream. And if you excite the inhibitor, then you're going to inhibit the downstream. So a alpha-2 receptor agonist, such as clonidine, which stimulates the alpha-2 receptor, is going to cause an increased inhibition downstream. But if you inhibit the inhibitor, it is going to enhance the downstream effect. All the others, beta receptors, these are postsynaptic. And if you inhibit them, you inhibit the activity of the sympathetic nervous system. And they come in different varieties. Beta, this can also beta 1, beta 2. And, but what we use here is non-selective. And then we have the alpha 1, alpha 2, which I'm really talking about in about 10 minutes. So let's take a break and come back in 10 minutes at 3 p.m.
Oh, wait, just a second.
One second.
I can also run the attendance right now, Doctor.
Okay, run attendance. All right. All right, thanks. See you in 10 minutes.
to the last stretch here. So let's talk about sympatholytics. If there's anything specific in the treatment psychopharmacology of PTSD, am I being heard? Yes. It is sympatholytics. And as we discussed at the quiz, there are different kind of adrenergic receptors. And again, don't forget adrenergic means norepinephrine or epinephrine. The alpha-1, alpha-2, and beta receptors. Again, beta comes in different varieties, 1, 2, and even more. And alpha-2 is distinguished by the location of the receptor being presynaptic, so therefore it's inhibitory. Propranolol, as I mentioned at the depression lecture, it can be used for certain psychiatric reasons, but it is FDA approved for a variety of non-psychiatric reasons. It was first approved for hypertension. In fact, it was one of the first anti-hypertensive medications available. Later, it became available for migraine prevention, then essential tremor, which is a neurological condition, and then various kind of arrhythmias. What it does is it slows down the heart. It develops tachycardia from, prevents tachycardia from developing, and if tachycardia develops, it pushes it back to normal levels. And one of the advantages of propranolol, especially in low dosages, that it does not reduce the heart rate or blood pressure below normal. Of course, it can be if you overdose on it, but because of that, it's pretty safe in the dosages of the use in psychiatry, which is usually less than 40 milligrams. Really, really rarely up to 80 milligrams. You don't have to worry about that. In psychiatry, it's used for panic attacks, performance anxiety, and akathisia. And there were studies, as I mentioned in the beginning of this section, that they tried to use propranolol to tweak the fear conditioning response that occurs in PTSD. It would be, the idea was that if you can prevent fear consolidation with a beta blocker, then there will be no PTSD. However, it does not happen. Fear does consolidate even though there is a beta blocker on board. It does attenuate the emotional responses in the acute setting, but does not impair recall, and there is no effect later on the subjective symptom severity. So the severity of PTSD, for instance, CAT scores and stuff like that. However, there's a new interesting study that has been published very recently. It's called pharmacological reconsolidation blocking. So this is for people who develop PTSD and go through a therapy called reactivation therapy. I think it's like one of those things Dr. Myers knows, the narrative therapies, etc. Yeah. So these are specifically manual. It's like a manualized thing that was described in this study, and you can read it if you find the article. They specifically and deliberately evoke the traumatic memories, reactivate, so the patient gets into activated state, and then they give the patient a propranolol. And what they did was actually a very high dose propranolol, which typically you would not be using in psychiatry. So they gave 1 milligram per kilogram sustained release and the 0.67, so basically 2/3 milligram per kilogram immediate release before the reactivation. So what this combination does is that the immediate release gives a big boost at the first few hours, and then the slow release gives a very long taper down blood level. So there were 6 weekly sessions. Comparative with drug and placebo, and there was significantly different improvement with the active drug, which was propranolol. I forgot now what the placebo was, but there was significant improvement in both the CAPS and the PCLS measures of PTSD. So this is something very new. If you know how to do reactivation therapy, then you may want to try, after you familiarize yourself with this article, to give patients propranolol. Again, as you know, we're talking way out of FDA approved anything here. So we left it past behind us at the SSRI section. Everything that we have been talking is ever since. And what I'm talking coming is just way outside of FDA, and even more way outside of FDA. So let's talk about prazosin. Prazosin, otherwise it's known as prazosin or prazosin, depending on who you talk to. If there is any medication specific for PTSD, it's prazosin. It is FDA approved for the treatment of hypertension. It's a very old hypertension medication. The brand name is Minipress. It is virtually never used anymore for blood pressure for a variety of reasons. Actually, one of the reasons is that it has a unpleasant initial effect, which I'm going to detail on the next slide, and also because there's tolerance that develops to the blood pressure, to the antidepressant effect. However, looks like tolerance does not develop to the effect that we use in PTSD, which is a good thing. So it was found to be effective in reducing nightmares and overall PTSD symptoms, such as the CAPS score, etc., in many, many early small randomized controlled trials, and then a meta-analysis of those trials. But then there was a big study at VA, which was a very well-controlled large study, that to everybody's surprise did not find prazosin to be helpful, either in the primary outcomes, such as sleep or nightmare symptoms, which was actually the focus of the study, the secondary outcome, which was the CAPS score, etc. And therefore it was removed from the list of medication recommended to the VA for PTSD, but nevertheless it's still widely used at the VA or anywhere else. There is criticism of this study that the patient population of this study was very different from the patient population of the other small RCTs. And I bet that there's going to be another study in a different patient population that will evaluate prazosin. So how to use prazosin? You typically start at 1 milligram at bedtime, and then it gradually increases to 3 to 15 milligrams as tolerated. And when I say gradually, I mean every 2 to 7 days. There was one study that showed a really very high dose prazosin, up to 45 milligrams. And with good tolerability. And again, it shows you that it is really not a medication that would do much for blood pressure because if it was a very effective blood pressure medication, nobody would be able to tolerate 45 milligrams. But actually, I have a patient who is taking 40 milligrams of prazosin after I read this study and I discussed it with him. This gentleman is a CHP, which is a California Highway Patrol officer who developed PTSD in the course of work. So he's on 40 milligrams of prazosin and doing well, relatively well. So what is the problem with prazosin? It has what's called the first dose effect. You take the first dose and there is a really high risk of orthostatic hypotension. So patient gets up, blood pressure drops down to below 60, falls, and of course then can suffer different kind of injuries. And especially bad in the elderly as a side effect. So that's one of the reasons why the first dose should never be higher than 1 milligram. In fact, again, because I'm a cautious guy and always go lower than most people. Sometimes it's a capsule, so you can cut it. I ask patients to just pour out half of it and just take a half milligram, and then there's nothing happens, and go to 1 milligram the next night. And basically what you do with this medication, like with many other medications in psychiatry, it starts low and increasing gradually and titrate it to effect. So it's at some point when the effect begins to appear, then you stop the increase. Clinically, I would say that it's effective about 50-60% of the cases. There are many patients who have absolutely no response to the prazosin, and some patients have partial response. It means that their nightmares get better. VA as a secondary game problem evaluating outcomes. So, the partial effect is that you may see that there are still nightmares, but they are either not waking the patient up, or doesn't remember them in the morning. It just knows, yeah, I had a nightmare, but I don't remember. Or they wake up and the nightmares do not have that really very strong emotional effect on patients. So these are the partial effects, and then the nightmares may completely go away.
In daytime.
But even a partial effect is better than nothing. So if you don't achieve full resolution of nightmares, but you achieve any of these partial resolutions, then you continue. What can be a side effect, and it's not in the slide, so you can make your note. The most important side effect, other than the first dose effect, is headaches. Some people will not be able to tolerate prazosin because of really bad headaches, which begin to occur after not really the first dose, but within the first week, towards the end of the first week. And that makes it impossible for them to tolerate, which is sometimes very disappointing, because they do have a response to it, but then they have to stop eating because the headaches are just so bad. So please, sorry it's missing from the slide, but that's the clinically most limiting side effect. The problem with prazosin is if you suddenly stop taking it, it can result in rebound hypertension. So you should never do that. Decrease it gradually. It doesn't have to be very gradual. You can just increase it, 2 milligrams every couple of days. It can be used either adjunctively or as monotherapy. Adjunctively, of course, you could use it in addition to whatever else you're treating. If you're treating lack of appetite, if you're treating hypervigilance, if you're treating depression symptoms, you can treat the sleep problems with prazosin. Or if patient really doesn't have much problem other than nightmares, but psychotherapy is taking care of most of the symptoms themselves, then you can use prazosin alone. You can also use prazosin during the daytime. One of the things that prazosin does is it can reduce hypervigilance. So one of the things that you can try to do with prazosin, if you started it started the patient at night and tolerating, and it's working reasonably well. And the patient has daytime hypervigilance, then you can also try adding a lower dose of prazosin during the day. So that's the patient of 5 milligrams of prazosin at night for the nightmares, and 1 milligram prazosin in the morning, or 1 in the morning, 1 in the middle of the day for the hypervigilance. Clearly, it's probably the nightmares are, in a way, if you want to look at it, as hypervigilance during sleep. So it's probably there's something similar or something common in the mechanism that creates nightmares at night and hypervigilance during the day, that the same medication can affect that. And there are patients who nightmares do not respond to prazosin, but nevertheless they get some effect on hypervigilance in the morning. So really, believe me, there's rules. There are something that do not exist in PTSD. But again, this is a very versatile medication, and something that if you treat PTSD, you will use it. Any questions about prazosin? Okay, if no, then let's go to some other adrenergic receptor alpha-1 blockers. That if you have somebody with a really bad hypotensive effect, otherwise responding well to prazosin, but can't take it because you just can't get out of bed at night because it's so dizzy and lightheaded, then you can try doxazosin or terazosin. Actually, there is some studies with doxazosin that show effect, and there's the advantage is there is less first dose effect, and it's not as strong antihypertensive as prazosin. And then terazosin has even fewer studies, but again, the neuroscience behind it is the same. And if you're wondering what BPH is benign prostatic hypertrophy. HTN is hypertension. All right, so alpha-2 adrenergic receptor agonist. So there's nothing as specific to PTSD as prazosin. All the others are, and there's there's also runs, not as specific and not as effective. But one of them you can try to use for hypervigilance, clonidine, which is FDA approved for hypertension and ADHD, and is also widely used for opiate withdrawal. Guanfacine is a similar medication, alpha-2 receptor agonist, also approved for hypertension and ADHD. Izanidine, another alpha-2 receptor agonist, which is, who knows why, that FDA approved as a muscle relaxant. So imagine the exact same mechanism for hypertension, ADD, and muscle relaxation. There's a single little FDA sponsored study that indicated some effects on nightmares. Advantage of izanidine that it virtually has no effect on blood pressure. I had a couple of patients who I switched from prazosin to tizanidine with good effects on the nightmares without the side effects. And again, these were patients, again, you should try to combine medications to address as many symptoms as possible. These were also patients with different kind of chronic pain and muscle pain symptoms, fibromyalgia, etc. So again, we have case reports. There's nothing evidence-based, but they can help with hyperarousal and nightmares. Good old benzodiazepines. They are really rarely studied in PTSD, yet they are very frequently used to treat symptoms of anxiety and hyperarousal because they are, frankly, pretty effective in like a huge hammer kind of way. Some data suggests, as Dr. Myers mentioned, that benzodiazepine may impair the therapeutic effect of treatment, such as exposure therapy, that rely on extinction learning. Definitely they should be avoided in PTSD with a history of substance abuse. And it goes without saying that all patients have been monitored for signs of abuse of the prescribed drug and signs of abuse for any other drugs or any kind of doctor shopping and medication overuse. Anybody knows about the CURES system? CURES. Okay, it's CURES. I'm not sure what it stands for. It's an abbreviation. It is
California. I think it's California only.
no, because I think it's national. I think every state has a CURES system. It is basically a reporting system that any person who gets a drug that is scheduled 3 or 2 gets reported into the system, and you can sign up with it as a licensed provider, and you can check your patient's prescriptions that are prescribed by others. So let's say you have a patient who is on prazolam, and you log in, and you can see your prescriptions that patients picks up month after month after month, and you see that nothing else is being picked up. So you can sort of get assured that at least not from pharmacies, the patient is not getting any other medication. But sometimes you get surprised, you log into the CURE system and you have a patient who you've been giving, the prazolam, and suddenly you see that she's getting clonazepam from somebody else and is getting Adderall from yet another person. And it's a very useful thing to do. So each state, I think at this point, maybe one state who refused to sign up, I'm not sure exactly which one, but each state has this reporting system. And in California, it's called CURES, CURES. Actually, I think it's called PDMP, prescription drug, something. Anyway, so you can find it, and if you are a licensed provider, I presume that you will be able to sign up for it, and you can check your patient's scheduled medication use. So despite all these things, it is really hard to find a PTSD patient who does not have some benzo prescribed in clinical practice, especially because so many patients are not seen by psychiatrists, but seen by primary care providers for whatever diagnosis they make. And again, frankly, psychiatrists are not much better sometimes. So again, it is very frequently your patient's going to be on the benzodiazepine. And once they're on it and they find it effective, it's going to be very hard to get them off. And I'm not saying they should never use benzos, but I'm just saying that you have to be careful. Mood stabilizers. So mood stabilizers have been very useful in the treatment of many other psychiatric disorders, including treatments of depression, bipolar, but not PTSD. So they have tried, did studies with lamotrigine, topiramate, valproate, tiagabine, and they were all negative. There was really no use for these medications in PTSD. Let's talk about a little bit about ketamine. Ketamine is, of course, a new kid on the block, and its use has been exploding in the past few years. There are many randomized controlled trials that show really rapid reduction of PTSD symptom severity compared with an active control agent, which is midazolam. And I presume you guys know what midazolam is. It's a benzodiazepine, a very short-acting benzodiazepine. That's what you get if you have a very short medical procedure. And you get the injection and you wake up in the waiting room and it was done and you didn't even remember it was done. As I mentioned to you in one of the other slides, that there's a study with severe burn victims that who had less PTSD symptoms, when they received ketamine anesthesia during bandage changes, then in less severe burn victims who did not need ketamine, and therefore did not require anesthesia. This is a military study. So it may even be, so certainly it means that, that theoretically, at least in this instant, it supports that it may be used for secondary prevention of PTSD. Again, it would be hard to press for the idea that anybody who is about to, or is likely to get PTSD or has high risk of PTSD should get ketamine. But again, theoretically, you can make the case for that. I would say that maybe somebody's going to do a study with some other NMDA antagonist. I'm not aware of anybody doing a study, but I'm sure that somebody's already thinking about it. Something like dextromethorphan or something like that. But on the other hand, as the second side, the bottom side of the slide shows, there were 50 accident victims with acute stress disorder who got ketamine or opiate or an NSAID in the emergency room because of their injuries. So they happened to get ketamine, happened to get opiate, or happened to get NSAID, which probably was some kind of an injectable NSAID. Comparison showed that those who got ketamine had the increased dissociative symptoms, increased arousal, and increased avoidance later. So the picture is not as rosy. Again, these were not in any way systematized studies, but these are case reports, and they have to be evaluated as such. In our practice, we do ketamine with PTSD patients, and I have to tell you that it is not failing the studies. People are showing very rapid reduction of PTSD symptom severity, usually after the first treatment. Hypervigilance and even numbing seems to be responding to ketamine. So it is becoming a very effective treatment. We also have a combined approach, or where we do ketamine one day, and then I do ketamine one day, and Dr. Myers does the psychotherapy on the next day. And again, as it was mentioned in the depression section, ketamine, if you look at that way, loosens up the neural machinery of the hippocampus, allows more learning to take place, allows new synapses to form, with prolonged use, perhaps even new nerve cells to form, and just as in depression, it seems to underlie the effect of ketamine in PTSD as well. Question? No question. So treatment of additional symptoms. So again, as Dr. Myers mentioned, one of the things that you do with PTSD is you treat symptomatically. I mean, yes, PTSD is a diagnosis, but again, compared to depression, the variety, the nature of symptoms, the variety in which symptoms come is much more extensive. So you will be using medications according to these symptoms very liberally. So if you see somebody, with sleep problems, sleep medications. substance abuse, then you could treat the substance abuse with that particular medication, for instance, naltrexone. Antipsychotics, besides just simply helping PTSD symptomatology, the CAP scores, etc., may be useful if hyperarousal, hypervigilance reaches psychotic proportions. How does hypervigilance reach psychotic proportions? It doesn't occur frequently, but it can happen. And the way it happens is that eventually generalizes into stimuli that are not remotely trauma related. The person begins actually to become suspicious about people, not just avoiding people. And this paranoid suspiciousness is where it sort of like leads into psychosis. Hearing voices is really extreme, occurs very infrequently. Most likely, psychotic symptom in PTSD would be paranoid, would be the hypervigilance reaching really paranoid levels, levels that are really unreasonable, no longer really just related to the traumatic experience. And in these situations, you would use, of course, antipsychotic. Again, if you want to be fancy, use iloperidone, which would be hitting two neurotransmitter systems at the same time. If you want to go safe, then just use risperidone. If you need to address sleep issues, then use quetiapine. If you have problems with mood, really severe, depression, then consider aripiprazole. There is another form of PTSD and psychosis, and it is not on this slide. I actually just thought about it. There is PTSD that can occur as a result of psychosis. Just imagine that you have a psychotic vision, and you think that the devil is chewing on your leg, and those kind of horrible things, and you are really, really afraid. And when people get treated and they come out of psychosis, they retain these memories, and these memories can be the source of PTSD, which I have seen a few times. So then you have not a PTSD reaching psychotic levels, but the psychosis causing PTSD. In that case, you would treat PTSD as PTSD, you would continue treating the psychosis as well. Again, if you want to be interested in psychopharmacology, then start with Fanapt, iloperidone. But again, you can just continue whatever treatment the patient is having, and then you can treat the individual symptoms of PTSD with whatever medication you want. Probably you want an SSRI, you probably want an alpha-1 blocker, and whatever else you may be necessary. I had one interesting case which is very loosely but related to this question. I had a patient who was really psychotic, and he was kind of single symptom psychosis. He had a voice in his head whose name was, I forgot now, whatever it was. And she kept hearing his voice, and she was able to work. It says difficult because there's no actual exposure to event.
Psychotherapeutic, maybe.
Well, there was no actual exposure to the event, but as far as the memory is concerned, the memory has happened. So you were exposed to something, whether it was really happened or you just thought that it happened. So the effect of that memory on your brain is is the same. Anyway, so this patient was psychotic and was hearing this voice and tormented her all the time. And she was taking some Haldol, and I took over the treatment. And what kind of treatment? It's also with cognitive behavioral treatment. So stop personifying the voice, don't call the name, and just call the voice, etc. Eventually, the voice started to recede into the background and disappeared, but then it reappeared in her dreams as a nightmare. So the voice talking to her in her dreams, and she was very disturbed by that. She didn't hear the voice during the day, but it was like an audible nightmare at night. And interestingly enough, prazosin helped her. It made this kind of a hallucinated, dreamed voice go away. Okay, so back to the treatment of additional symptoms again. So you use these medications for the sleep problems. Hydroxyzine, of course, is a prescription antihistamine over the counters, as you would otherwise use them. Try to avoid the benzos and the Z drugs. And again, there's a large number of medical symptoms in PTSD patients. First and foremost, pain. They also often develop cardiovascular symptoms because of the sympathetic hyperactivation, etc. So you have to look for these, and you don't treat them, but you refer them, refer the patients to the appropriate providers. Augmentation psychotherapy with medications. So clinical research has not found a combination of SSRI and SNRI and CBT leading to a greater sustained improvement than either modality alone. In clinical practice, they have the approved meds used widely on pragmatic consideration in patients who are in psychotherapy. The specific combination is trying to facilitate, which is coming up nowadays, the coming up of combination medications to facilitate the extinction learning and prolonged exposure therapy. These are different kind of propranolol. These are experimental treatments, and these are the different kind of gray area treatments. Cannabis. After alcohol and marijuana is the most frequently abused drug in PTSD. There have been studies now at the VA with THC. It showed statistically significant improvement in CAP score, sleep quality, frequency of nightmares, hyperarousal, and also with CBD. Again, don't forget, as I mentioned before, PTSD sufferers self-medicated with cannabis for a good reason. It helped them. And again, as cannabis is becoming more and more legalized in the US, I think that this is going to be coming up very, very quickly. So in the final section, I would like to talk about the gray areas. This is really just for your amusement. This is not something that I would even be on the exam. But this is the future, at least that this looks like this is the future. So I think it's important to know about them. So let's look at MDMA. MDMA is an interesting chemical. It looks like a combination of dopamine and methamphetamine. The only difference is that, the two oxygens are taken together with a methylene group. And just to make sure not to be confused with NMDA, which is a certain antagonist of glutamate receptors, glutamate ion channel receptors, on which many medications act, such as ketamine. They use the same letters, but they're not the same. So MDMA is classified as an entactogen or empathogen, so it creates empathy. I think entactogen is a better word because empathogen has the word pathogen in it, and I think it should somehow doesn't look good. It has a stimulant quality. It comes obviously from being associated with methamphetamine, and it creates positive mood changes. It increases arousal. It increases empathy. That's why it's called empathogen. It increases the sense of intimacy. It's a pro-social drug, and improves communication between people. Acts primarily as a presynaptic releasing agent of serotonin and substantially less than norepinephrine and dopamine. How does it work? It's a substrate for these transporters, which means that they get taken up into the presynaptic butan instead of dopamine, instead of norepinephrine, instead of serotonin. Therefore, so first of all, they increase the available serotonin or whatever compound in the synapse itself. They get taken up into the presynaptic butan. And then they get transported back into the synapse. So they act as if they were neurotransmitter released by the neuron itself. It has a duration of action which is fairly long. It ends with depletion of serotonin levels in the brain. Sometimes it can lead to like temporary reduction, lowering of mood. It's metabolized by these enzymes as well as COMT. There's clear toxicity involved with repeated high dosages. It may lead to a permanent depletion of serotonergic axons. So MDMA has entered clinical studies, so much so that there has been even a meta-analysis of MDMA psychotherapy. There were 5 published studies meeting criteria. Basically, it looks like there is a dose dependence effect. Higher dosages seem to be more effective. Seems to be effective not just in the moment, but seems to have a enduring effect. And looks like the number of sessions, also the more sessions you have, the more effective the treatment is. So based on this meta-analysis, the FDA has now granted a breakthrough therapy designation in order to expedite the approval process. So you can imagine that your little ecstasy that you might have done when you were younger in some dance events, that is now becoming an FDA-approved medication for PTSD. So much so that now the first phase 3 study that is now underway in 16 sites in the US, in Canada, and Israel. As to how to do the therapy, I will not talk about, but I will present the link a little bit just further down. You can go to a website, and that website will tell you in great details. And if you're interested, you can even sign up, become an MDA therapy provider for a decent sum of, I think, $7,000 or something like that. On the increasing level of grayness, we have reached psilocybin, which is, of course, the active ingredient of the magic mushroom. The active component is psilocin. Psilocybin is this compound combined with this phosphoryl group. It gets chopped off when it gets into the body, and this is the active ingredient. It's called psilocin. And you can see that psilocin is very similar to serotonin. Basically, just this hydroxyl group moved from here to here, and there's 2 methyl groups here, and there you have the psilocin. So what psilocybin or psilocin does, according to studies, it reduces activity in the amygdala and the hippocampus, which reduces communicating fear and threat signals to the frontal cortex. It has now been studied for alcoholism, smoking cessation, and in patients with advanced cancer with anxiety. There is studies that show that psilocybin makes autobiographical memories more vivid. It may be more useful in psychotherapy, either as a tool to facilitate the recall of salient memories or reverse negative cognitive biases. This is the website if you're interested. It tells you more about both of these agents. These are just other agents that are being in the process of being studied. It's way into the future, if ever. There's an interesting study with yohimbine, which is an alpha-2 receptor antagonist, so it inhibits the inhibitor. It is available as a prescription pill and as a supplement. It is not FDA approved for anything, but it is used for erectile dysfunction. It's a norepinephrine releaser in the central nervous system. Veterans with PTSD who used over-the-counter yohimbine for erectile dysfunction had exacerbation of anxiety and panic and PTSD-specific symptoms. The experimental administration triggered flashbacks, but now there is a randomized controlled trial that is planned to enhance exposure therapy with high-dose yohimbine. Why 21.6? I'm not sure, but that's the dose that they are doing, and it looks like increasing the emotional activation during re-exposure can increase the outcome of therapy. And animal studies have been done that indicate effectiveness in extinction learning. Again, something for the future. But again, if you have a veteran and suddenly he has more PTSD symptoms, then you may want to ask if he got some yohimbine. And finally, we have a quiz, and that will be the last thing we do today. 44-year-old male, former pilot with PTSD and chronic pain treated with high. I'm sorry, just pausing my screen. Team for follow-up visit. After years of stability, he now reports the reappearance of flashbacks. On questioning, he tells you that he started taking over-the-counter drug a few weeks ago, but he doesn't remember its name. What is the most likely answer when you ask him what he picked up from the pharmacy? Something for sleep, something for pain, something for impotence, something for itching. Okay, so we have the 80%. So those who paid attention to the last slide got it right. Something for impotence. And that would have been yohimbine. So that concludes the psychopharm, medication presentation section. If Dr. Myers has anything to say, yeah, she says no. So at this point, then I would say that good luck to all of you, and for the exam, and also in your studies for your future career. Thank you.
They have to do it. I think they have to do it.